Support for the Journal of Clinical Oncology podcast is provided in part by AstraZeneca, dedicated to advancing options and providing hope for people living with cancer. More information at AstraZeneca-US.com.
The guest on this podcast episode has no disclosures to declare.
Hello, and welcome to our 2025 ASCO annual meeting series, where we cover some of the top JCO papers published simultaneously with their abstract presentations at this year's meeting. I'm your host, Dr. Lauren Shih, JCO Editorial Fellow, and I'm joined by JCO Associate Editor, Dr. Stephanie Wheeler, to discuss the Journal of Clinical Oncology article and abstract presentation, Use of Low-Value Cancer Treatments in Medicare Advantage versus Traditional Medicare. Let's start with the relevance of the article. Dr. Wheeler, can you explain this to our listeners?
Thank you so much. Let's get right into it. So this article is really about understanding different types of Medicare plans and what we should expect to see in terms of their use of low-value treatments for cancer patients. So as Medicare really is focused on trying to limit the use of low-value cancer treatments, we really need to better understand the drivers of variability. So we know that many cancer patients have multiple treatment options available to them. We also know that the vast majority of older adults beyond age 65 are insured by Medicare, and about half of them are on Medicare Advantage plans, which are serviced by private insurance. And private insurance companies in this case are receiving capitated payments for Medicare beneficiaries to manage their service utilization and reduce costs. So with respect to Medicare Advantage versus the traditional fee-for-service Medicare, it's not really been known to what extent low-value treatments are differentially used by these types of plans for cancer patients. And so that was really the focus of this article. What the authors found is that across 6 different types of treatments, in general, the folks who were enrolled in Medicare Advantage plans had reduced use of low-value treatments. So that's a good sign for Medicare beneficiaries. And although the relative difference in that use was somewhat low, this translates to a significant number of Medicare enrollees across the country not receiving, these low-value treatments. And of course, this translates to considerable savings at the society level.
Are there any additional key results that we should review?
Yeah, so I'll tell you just a little bit more about the methods and also their findings. So they looked at 6 different low-value treatments, and this was in, again, 100% of national Medicare enrollees from 2015 through 2021. So the 6 low-value treatments that they examined were the use of G-CSFs among patients receiving low-risk chemotherapy and denosumab for those who had castration-sensitive prostate cancer. Then they also looked at 4 high-cost treatments, including using nab-paclitaxel instead of paclitaxel for patients with breast or lung cancer. Second, adding bevacizumab to carboplatin plus paclitaxel for ovarian cancer. Third, using brand name drugs instead of generics when generics were available. And fourth, using biologics instead of biosimilars when biosimilars were available. And these are all, by the way, non-recommended treatments according to a variety of guidelines, including NCCN and ASCO's Choosing Wisely guidelines. So they used the Medicare claims data to examine use of these regimens. They also analyzed results by type of Medicare Advantage plan, whether people were enrolled in a health maintenance organization plan or an HMO, or a preferred provider organization plan or a PPO. They also looked at the largest Medicare Advantage insurers, including Aetna, Blue Cross Blue Shield, Cigna, Humana, and United Health, and limited their analyses to those that had complete encounter data. And what they found across the board is that the enrollees in Medicare Advantage plans generally had lower use of these low-value treatments, and the largest differences between Medicare Advantage and traditional Medicare plans were in the outcomes, including G-CSF use, and using denosumab for castration-resistant prostate cancer, and then the combination of bevacizumab, carboplatin, and paclitaxel versus carboplatin and paclitaxel. And all of these had a change in use ranging from about 19% change to 24% change in use. This is significant as a field as we look at ways in which different plan organization can influence use of treatments. particularly given the excess cost of cancer care. This is something we really want to pay attention to. So I'd encourage folks to look more closely at the results by treatment type as well as the results by plan type to see a little bit more about what was going on across different plan types.
Great. And are there any outstanding questions that need to be answered?
Yes, there always are, of course. I think the study has several strengths that are worth noting. First, they have 100% of Medicare enrollees, so there's national coverage there, which is, quite outstanding. They also use an appropriate choice of analysis to help deal with some of the selection. So they use inverse probability of treatment weights, and they control for practice and county indicators to try to get some realistic adjustment for the selection that happens in terms of how patients are enrolled in different Medicare Advantage versus traditional fee-for-Medicare plans. These statistical approaches are a good idea, but they are limited by the observed variables that we can use for these kinds of adjustments. And so any unobserved confounding or any unobserved factors that would influence selection in these plans aren't going to be captured well. So preferences, for example, that patients may have about different types of plans when they're insuring themselves and their families may not be captured. Second, the data that are used are only encounter data from those plans with complete records. That may mean that smaller Medicare Advantage insurers or those that don't have as comprehensive records are not included. So this may not be reflective of their practice patterns. And then third, of course, this only looked at 6 different low-value cancer treatments. It remains to be seen whether this kind of finding extends to other types of low-value cancer treatments, and that's an opportunity for future study. Finally, I would say that, we don't exactly know why these patterns exist. It could be that Medicare Advantage plans have different approaches to prior authorization. They could have more sort of in-house quality control and management to really understand among their population that for whom they're receiving Medicare Advantage payments to really look at care quality and assess choosing wisely guidelines. We don't know exactly how that's playing out. And so we need additional data to really figure out what's working here and what are opportunities for future policy and payment innovations that can further reduce low-value care.
Great. Thank you so much, Dr. Wheeler, for speaking to us about the JCO article, Use of Low-Value Cancer Treatments in Medicare Advantage versus Traditional Medicare. We really appreciate your insights.
Thanks for having me.
Join us again for the latest simultaneous publications from the ASCO 2025 annual meeting. Please take a moment to rate, review, and subscribe to all ASCO podcast shows at asco.org/podcast. Until then, enjoy the rest of ASCO 2025.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.